Hi everybody, this is Professor Schumann, and I'm going to be giving you the lecture on lung cancer that was presented first on Monday, September 28th, and some of you were unable to get to class, so I'm going to be repeating it for you, and we had a little glitch with recording it in the classroom that we were in, so that's why you're getting it as a narrated PowerPoint. Anyway, outcomes for this lecture are that at the conclusion, you'll be able to discuss the single most important risk factor in the development of lung cancer and nursing's role in decreasing this risk factor. You'll be able to identify the differences in pathology, treatment, and prognosis between small cell and non-small cell cancer. And you'll be able to describe the nursing management of a patient who has chest tubes. Lung cancer is the leading cause of cancer-related deaths. It accounts for about 28% of all cancer-related deaths in this country. And there is an estimated 225,000 new cases each year in the United States. It has a very high mortality rate. Even though we've made a lot of advances in treatment and improving the response to lung cancer, we still are not making a lot of headway with curing it. I said that a little backwards. What I meant to say was we are making a lot of advances in the medical treatment, and that is helping improve the response, but there is still a high mortality rate with lung cancer. It's one of the more fatal types of cancer. And as you probably can expect, the most important risk factor in 80 to 90% of all lung cancers is smoking. Cigarette smoke contains about 60 carcinogens that interfere with cell development. And what these carcinogens actually do is cause a change in the bronchial epithelium. The good thing about this change in bronchial epithelium, though, is that quitting smoking reverses this change in bronchial epithelium and therefore reduces your risk of getting lung cancer. And if you quit smoking, you gradually reduce your risk, and within 10 to 15 years of quitting, your risk is the same as a non-smoker. Your risk of getting lung cancer, if you are a smoker, is related to the total exposure to tobacco smoke. So we look at the total number of cigarettes you've smoked, the age when you started smoking, how deep you inhale, the tar and nicotine content, and whether you smoke filtered or unfiltered cigarettes. So this is where we talk about pack years when we're talking about people and smoking. And so if somebody smokes one pack of cigarettes a day for, let's say, 10 years, then we say that they have 10 pack years of smoking. So whatever they smoke, we try to make it equivalent to one pack a day per year. And so if they smoke, let's say, 3 packs a day for 20 years, that's equivalent to smoking 1 pack a day for 60 years. So they would have 60 pack years. So it's sort of a way to equalize and, be able to talk about how many cigarettes they've smoked over their lifetime and kind of compare people. Side stream smoke contains the same carcinogens as mainstream smoke, and that's why we're so concerned about secondhand smoke. And it is a health risk to non-smoking adults and children. And, that's why we're so concerned about secondhand smoke, because causes a risk of lung cancer for the people around them. And we now categorize people's risk for lung cancer into 3 categories: people who have never smoked, people who have smoked but have quit, and then people who are still smoking. And there is a tool that has been put out by Memorial Sloan Kettering Cancer Center that sort of helps to calculate the risk for developing lung cancer for smokers and former smokers who have quit smoking 20 years ago or less. And there's a website that you can go to if you're interested in that. It's worldwideweb.mskcc.org/prediction-tools/lung cancer. And if you know someone who smokes and you're interested in finding out their risk, you can go and find that tool there. Of course, there are other carcinogens in our environment that pose a risk for developing lung cancer, and they include pollution, radiation or radon. I don't know if you're aware of radon, but that's a chemical element that's in the ground, and it's in different areas, sort of. They call it, what do they call it? It goes in like a long streak. And so certain areas will have more radon than others. And you can get a system in your home. If you have a high amount of radon, you can get a radon reduction system in your home. And I don't know exactly how it works, but I know the people next door to me had one put in. And it supposedly, reduces the amount of radon in your home. Other pollutants are things like asbestos and industrial agents like nickel, uranium, chromium, formaldehyde, arsenic. So people maybe who work in chemical factories, might be at higher risk for lung cancer. And of course, miners, coal miners are also at a higher risk than the normal population. We don't have a lot of coal mining going on anymore, but when we did, those miners were at high risk for cancer. And then there's also genetic factors and, of course, gender differences. We used to have men getting more lung cancer than women, but since we have more women smoking than we used to, females have just as high of a risk of getting lung cancer, and actually female smokers have a higher risk than male smokers of developing lung cancer. And there is a gene, they don't know exactly why, it's not well understood, but they have discovered a genetic factor, and they've named it epidermal growth factor receptor gene, EGFR, that may be linked to familial lung cancer. So this may be why some smokers, do develop lung cancer, and then other ones will brag, I've smoked for 50 years and I don't have any cancer. So it's, like I said, it's not well understood why that is. The pathophysiology of lung cancer is that it arises from mutated epithelial cells, and the tumor development is promoted by this epidermal growth factor. And it usually takes 8 to 10 years for a tumor to reach 1 centimeter, which is the smallest lesion that's detectable on an X-ray. So usually when it is detected, it's been growing for quite a while. And it occurs primarily in the segmental bronchi and the upper lobes of the lungs. So this is where, for whatever reason, tumors tend to grow. The primary lung cancers are categorized into 2 main subtypes. And the majority of lung cancers are non-small cell lung cancers, about 80% of all lung cancers. And a smaller percentage, only 20%, are these small cell lung cancers. And there's some major differences between these two types, which I will talk about. The non-small cell lung cancers are the squamous cell carcinomas, the adenocarcinomas, and the large cell carcinomas. And these all have different growth rates and different types of symptoms. So, we'll talk about those a little bit. The squamous cell carcinomas are very slow growing. They're usually very centrally located, so they produce early symptoms of a non-productive cough and hemoptysis. They don't tend to metastasize too much. They are very often, it's possible to surgically resect them, and they also are receptive to chemotherapy and radiation. And they are, depending on what stage when they're discovered, life expectancy is better than for small cell lung cancers with the squamous cell carcinomas. Adenocarcinomas have sort of a moderate growth rate compared to the other tumors. These are the most common ones that are found in non-smokers, and they're more common in women. They're usually more peripherally located and oftentimes have no clinical manifestations until widespread metastasis is present. They don't respond well to chemotherapy, so they tend to be more fatal than some of the other cancers. Large cell carcinomas are very rapidly growing and highly metastatic. They only account for about 10% of lung cancers, and they're composed of large-sized cells that are anaplastic and often arise in the bronchi. As I said, they're highly metastatic via lymphatics or the bloodstream. And usually they're not surgically resected because they usually, when they're discovered, have already metastasized to several sites. They may try radiation with them, but unfortunately they often recur. So even radiation is not real helpful with these large cell carcinomas. Small cell lung cancers, which are the smaller percentage, as I mentioned, grow very rapidly. They're the most malignant of all the lung tumors. They metastasize very early in their course. They also spread via the lymphatics and the bloodstream, frequently metastasize to the brain. They're also associated quite frequently with endocrine disorders. They're usually not surgically resectable. So chemotherapy and radiation is usually the treatment of choice, but they're usually do not have a good prognosis, unfortunately. This picture is a picture of a peripheral adenocarcinoma. You can see it up here. And the black pigmentation that you see is suggestive of it having evolved from an anthracotic scar, meaning that it might have developed from some exposure to coal mine dust and so forth. And I have another picture. This one's really gross. This is just all tumor here and really infiltrating the whole entire lung. And this was a squamous cell carcinoma, which pretty much had taken over the whole left lung here. Metastasis with lung cancer, as I mentioned, can be through the blood, the lymphatic system, or by direct extension. And the most common sites are the liver, the brain, the bones, the lymph nodes, and the adrenal glands. There's something called paraneoplastic syndrome that can occur with lung cancer, and it's caused by factors that are produced by the tumor cells. And it causes variable symptoms, including hypercalcemia, syndrome of inappropriate ADH secretion, adrenal hypersecretion, and hematologic and neurologic disorders. And it's often associated with small cell lung cancer. And a lot of times these disorders that occur with paraneoplastic syndrome will resolve when you treat the underlying cancer. The manifestations of lung cancer typically don't appear until late in the disease. The first thing that you usually have is a chronic cough, and the other symptoms will really depend on the type of the primary lung cancer, the location, and where it has spread to. Some of the things that you may see is a pneumonia that does not respond to treatment. And as I said, one of the most frequent early symptoms is a persistent cough with sputum. Also, blood-tinged sputum may be present with dyspnea, wheezing, and chest pain. Later manifestations of lung cancer may be things like anorexia, fatigue, weight loss, nausea and vomiting. Hoarseness may appear later on as a result of an involvement of the laryngeal nerve. The patient may develop unilateral paralysis of the diaphragm. They may develop dysphagia and superior vena cava obstruction because of intrathoracic spread of the malignancy. They may have palpable lymph nodes in the neck or axilla, and they may develop mediastinal involvement, which may lead to pericardial effusion, cardiac tamponade, and dysrhythmias. The diagnostic studies that are going to be used to diagnose lung cancer, usually the first test that's going to be done is just a simple chest x-ray. And 5% of cases of lung cancer are found just incidentally on a chest x-ray that's done, for some other reason, just a routine chest x-ray, or just looking, for some other reason. And many times evidence of metastasis to the ribs or vertebrae or the presence of a pleural effusion can be seen on a chest x-ray. If a tumor is suspected, probably the next test they'll order is a CAT scan to further evaluate the mass. CAT scans can usually identify the location and extent of the mass in the chest, as well as any mediastinal involvement or lymph node enlargement. If the patient is coughing up sputum, it'll be very helpful to send that for cytology. They can usually identify then the pathology of the tumor, but a lot of times those malignant cells won't be present in the sputum, and then that sputum cytology will not be very helpful. So the best thing is to get a biopsy of the tumor itself, and that can be done either with a CAT scan guided needle aspiration, a bronchoscopy, a mediastinoscopy, or video assisted thoracoscopy. And I have a picture of some of these video assisted thoracic procedures. If a thoracentesis is done, they can also send that fluid for cytology and see if that has any of the malignant cells in it. And then they'll want to do some bone scans CAT scans of the brain, pelvis, and abdomen, more so looking for metastasis and metastatic sites. A CBC will be done, history and physical, chemistry panel, liver function studies, renal function studies, and pulmonary function studies. MRI and PET scans may also be done to evaluate and help stage the lung cancer. But this is a classification system that sort of helps to classify the stage of cancer that somebody is in, and sort of gives you an idea of not necessarily their prognosis, but how much it is spread. It gives you some idea of their prognosis, but sometimes it can be misleading. The T in the classification system denotes the tumor size, location, and degree of invasion. The N indicates the regional lymph node invasion, and the M represents the presence or absence of distant metastases. So this is a table right out of your textbook. So if somebody had a tumor that was small and localized to the lung with no lymph node involvement, it would be stage 1. And it could be stage 1A or stage 1B, depending on the size of the tumor. If the tumor was bigger and had some lymph node involvement, it might be stage 2A or B. If the tumor had spread to nearby structures, it might be stage 3A or B, and stage 4 would be distant metastasis, meaning to distant organs. You can see here that nearby structures are considered like the regional lymph nodes, heart, trachea, esophagus, the lymph nodes that are right in the area of the lungs. So distant metastasis would definitely be things like the brain, the liver, the bones. So patients that have stages 1, 2, and 3A disease might be surgical candidates. Patients who are stage 3B or 4 are usually inoperable and don't have a very good prognosis. This gives you more of a visual idea of what the stages mean. For instance, the picture on the far left gives you stage 1 disease where there's no metastasis. It's a very small tumor, very controlled, no lymph node involvement. Then the next picture is T1N1, meaning there's a little bit of lymph node involvement, but still no metastasis. The next picture is stage T2N0M0, meaning that the tumor itself is bigger, but there still is no lymph node involvement and no metastasis. And then the next picture, there's some lymph node involvement and a larger tumor. And then the next picture, a larger tumor, several lymph nodes involved, but still no metastasis. So again, it just kind of gives you, more of a visual picture of how it can progress. Now, small cell lung cancer, they don't even use the TNM system because it's such an aggressive tumor or such an aggressive cancer that it's always considered to be systemic because it grows so fast that, in a week's time, it could go from, no lymph node involvement to having lymph node involvement and metastasis. So it's really just staged as limited or extensive. And limited means that the tumor is confined to one side of the chest and the regional lymph nodes And extensive means that the cancer extends beyond the limited stage. And about 65 to 70% of patients with small cell lung cancer have extensive disease. And patients with extensive small cell lung cancer survive usually only about 12 months with treatment. And without treatment, they only usually survive around 6 weeks. And I've even heard, of patients who are diagnosed with small cell lung cancer dying in 2 or 3 weeks. I mean, it's so rapid. It's just really hard to take because they have just no time at all to adjust, really, and it's very, very quick. Screening for lung cancer is really recommended for high-risk patients only. For current or former smokers who have at least a 30-pack year history, or for former smokers who have quit within the last 15 years, who have no history of lung cancer, not on home oxygen, and who are between 55 and 74 years old. And the way they screen these people is to do a low-dose spiral CAT scan, and they feel that they can reduce deaths by picking up some of the early cancers this way. The treatment of choice for early stage non-small cell lung cancer can include pneumonectomy, which is removing the entire lung, lobectomy, which is removing, a lobe of the lung, segmental or wedge resections, which are removing sections of a lung. VATS stands for video-assisted thoracic surgery, and this can be done for tumors that are near the outside of the lung. It's not indicated for small cell lung cancer. And the pictures on this next page kind of show you how nice it is to have the video-assisted thoracic surgery. As we've done with so many surgeries nowadays, when they're done non-invasively, there's just so many advantages. The patient has a much smaller incision, therefore less pain, very quick recovery time. And so here you see the traditional incision, and particularly when you're talking about this type of surgery, the non-invasive is so much better, because if you have the traditional incision, you have to think about what's done here. Not only do you have, a big incision, but underneath this incision is the sternum. So the sternum then is also cut open, cracked basically, and the whole thoracic cavity is split open to get to the lungs. Well, remember how the physiology of respiration works. We breathe because there is negative pressure in our intrathoracic cavity. So when we open up the thoracic cavity here with any kind of surgical procedure, and this includes any kind of open heart surgery, we lose that negative intrathoracic pressure. So when they sew the person back up, they don't show it here, but anytime when they sew the person back up, in order to restore that negative intrapleural pressure, they have to put in a chest tube as they're sewing the person back up. The chest tube serves to remove all the air that has been let into that cavity so that we can re-expand the lungs. Now, I don't know if you've seen chest tubes on any patient, but in the classroom I passed around the trocar, the thing that they use to put the hole in, and it's about the thickness of a pen or a pencil, a little bit, it's about that thickness, but it's, and the chest tube itself is a little thicker than a pen or a pencil, and it's a semi-firm plastic, And that goes through the patient's skin and through all their muscle into their intrathoracic cavity. It's sutured in place here on the surface of the skin, and then it's attached to a chest tube drainage device, which we'll talk about in a little bit. So it's not comfortable. The patient has this huge incision. They're definitely going to be in the hospital for a couple of days minimum. They're going to have a lot of pain, lots of chance for infection. The pain is going to, give them reasons not to take deep breaths, so they're at risk for pneumonia. So our new alternative is to have this surgery where they just use a thoracoscopic surgery and put in these little tiny slits where they can put instruments through, and hold things out of the way and just make a little slit where they want to take the tumor out. And the person has just these little slits instead of this great big incision. They don't have to open up the pleural cavity, so the person doesn't need chest tubes. So it's really a huge advantage for the patient. So a little detour from the lecture for a couple of minutes here and talk about chest tubes and pleural drainage, because if you have that big incision that I just showed you, like I said, you're going to have chest tubes afterwards. And you will get an opportunity when you're in the skills lab to take a look at chest tubes and to take a look at the drainage device that we attach to the chest tubes. So as I said, the purpose of the chest tubes is to remove the air or fluid from the pleural or the mediastinal space, and it reestablishes that negative pressure that allows our lung to re-expand. You can either have the chest tubes in the pleural space or the mediastinal space, or both. The tubes are about 20 inches long. They can be various sizes from 12 French all the way up to 40 French. It depends on if they're just going to be re-expanding the space, they can be smaller. If they are going to be draining fluid, like if somebody has a chest trauma from a car accident or something and they have a lot of bleeding and they're going to be draining the blood, then they have to have a bigger tube because they're going to be letting, draining blood and clots and things. So the size of the tube depends on what they're putting them in for. So anyway, those are put in either in the operating room if it's after a surgery. If someone comes in, after an accident or something, they can be put in the emergency department. If somebody develops a collapsed lung, they can even be put in right on the nursing unit. These days, they're usually not going to be put in on the nursing unit. They're going to send them down to interventional radiology so they can see exactly where they're going. But they can be put in, just at the bedside. And I saw plenty of them done that way. And basically what they do, they look at an x-ray and determine if it's going to be for drainage or re-expansion of the lung. They look at where they need to re-expand the lung, basically. And they make a little slit in the skin after they give them some local anesthetic. And then they either put their finger in through here, as in this picture, or sometimes they'll use this trocar that I brought and passed around class and push it through here to kind of make a tunnel. And then they take the tube, here's a picture of the chest tube, and they pass it in through this tunnel that they've sort of made with their finger, and they push it through, pass it through all the subcutaneous tissue, the muscle, get it into the space in between the parietal pleura and the visceral pleura, which is right on the surface of the lung. So they get it in there, and these holes will help to drain the air. And then as you can see here, they suture it to the skin, and it comes out right here. And then, here's a couple more pictures. So it can be put in, up high. It can be put put in lower, it can be put in the mediastinal space, it can be put in posterior or anterior or lateral, wherever they need to, drain fluid or drain air. And here's a real good picture showing you how it's laying between the two pleura. And you can see how the lung has re-expanded because they've sucked the air out. Before they put this tube in, this lung was all shrunk down like a little balloon before it was blown up. And then as soon as they sucked the air out of here, this lung was able to expand. So that's kind of what it looks like from the outside. Now here's what the drainage device looks like. This is an old-fashioned sort of picture. I mean, many, many years ago, they used to use glass bottles to collect the drainage. Now we have, if we have a picture, the water will just go gently up and down, and that is called fluctuation or tidling. And that just means that the patient's lung is healing and the intrathoracic pressure is being restored to the way it should be. Now, if that tidling or that fluctuation stops, you need to take a look at your patient because there might be an obstruction somewhere in their chest tube. But if that's gradually going away, that's normal because that means the lung is expanding and the parietal and visceral pleura will form a tight seal around the chest tube opening. And eventually you won't have that tidling because it means their lung is healing and the hole around the chest tube is also healing. Now, as I mentioned, there is dry and water suction over here in this chamber. And I mentioned that if you're going to have water filled suction control, you'll fill the water up and you turn up the suction on the wall till you have gentle bubbling. Sometimes, though, the doctor will order dry suction, and then you will not bother with the water in this chamber. You will have a dial on the drainage system that will actually control the amount of suction. And they're using a lot more of the dry suction units now. I don't know why, but they just seem to be liking them more. So the nursing management of the chest tube setup. This is just a picture of the dry suction, and here's the dial that I was talking about. As I said, before they put in the chest tube, you're going to prepare the water seal and the suction control chamber by putting the water in. You're going to make sure that the chest drainage system never is raised above the level of the patient's chest. You're going to make sure that all the connections are taped so that nothing becomes disconnected. You're going to observe for tidling, observe for an air leak, which is bubbling in the water seal chamber. Observe fluid levels in the water seal chamber to make sure that it's always staying at that 2 centimeter. And of course you want to be assessing your patient, checking their vital signs, their lung sounds, making sure that they're not having too much pain, checking how much drainage is coming out of the chest tube, checking around the site of the chest tube insertion for subcutaneous emphysema, which is air under the skin, and it's described many times as like a Rice Krispie. When you touch around the chest tube insertion, it'll feel sort of spongy, and that just indicates that there's air leaking somewhere in the subcutaneous tissue. It's very important that you encourage your patient with a chest tube to do their deep breathing exercises and range of motion. They'll tend to not want to use their arm on the side of their chest tube because it, kind of hurts. But you want to make sure that they do use that arm, or they can get a frozen shoulder. They should keep a sterile, occlusive. You should keep a sterile, occlusive dressing around that chest tube site. And as I said, you're going to raise that chest tube drainage system above their chest. If they do have a lot of drainage, those chest tube drainage systems will collect up to 3,000 milliliters of drainage. So it's not too often that they get full, but if it does get full, you can change it and put a whole new system on there. As I mentioned, if the patient drains more than 100 milliliters an hour, you do want to notify the physician of that, because that could be excessive drainage. If for some reason that drainage system gets tipped over or disconnected, you don't want to clamp the chest tube. You want to take the distal end of the chest tube and place it in a cup of sterile water, and that will maintain the water seal till the physician can come and check the patient. The tube will be removed when the lungs have re-expanded and the drainage is minimal. Sometimes the surgeon or the physician will remove the chest tubes. Sometimes nurses can be specially trained to remove the chest tubes. They'll always get a chest x-ray after the chest tubes have been removed to make sure the patient did not have a pneumothorax when the chest tube was removed. Obviously, you'll monitor your patient for any respiratory distress after the removal, and you will place an occlusive dressing over that chest tube site. Back to talking about our patient with lung cancer now. Radiation therapy can be used as a curative therapy, as a palliative therapy, or as adjuvant therapy. It's primary therapy for those who are unable to tolerate surgery. It could be palliative for patients who are having symptoms such as dyspnea or pain, and it may be used preoperatively to shrink a tumor to make it a little more surgically, a better size to remove. You want to monitor your patient who is having radiation therapy for complications. And if you remember, I'm sure Dr. Erb did talk to you about complications. In this case, esophagitis would be a common complication because of the site of the radiation. Skin irritation, nausea and vomiting, anorexia, and radiation pneumonitis would be some of the complications that the patient may develop as a result of radiation therapy. Stereotactic radiotherapy, also known as stereotactic surgery or radiosurgery, this is where a high dose of radiation is accurately delivered to the tumor by a surgical technique, so that a smaller part of the healthy lung is exposed. It's usually done as outpatient therapy over 1 to 3 days. And this provides an option for patients who have very early stage lung cancers, who are not surgical candidates. It is a type of radiation therapy, but it's giving a higher dose, and it's more accurate, so it's saving more of the viable lung tissue. Chemotherapy is the primary treatment for small cell lung cancer. It's also a treatment for treatment of non-resectable tumors, or an adjuvant to surgery in non-small cell lung cancer. There's a variety of protocols that are used depending on the pathology of the tumor. It's typically a combination of 2 or more drugs. We're not going to, we don't expect you to learn the names of the drugs or anything like that. There's also biologic targeted therapies which block the tumor growth. These are less toxic than chemotherapy. And again, you don't need to know the specific names, but just that they block the growth of the tumor cells. And of course, there's a lot of research being done in this area to try to find new ways of treating the tumors. Prophylactic cranial therapy for small cell lung cancer to prevent cerebral metastasis. There's bronchoscopic laser therapy, which removes obstructing tumors from the mainstem bronchus. There's photodynamic therapy, which is used to treat very early stage lung cancers in the outer airways. Other therapies that are being researched and tried: airway stenting, radiofrequency ablation, electric current that heats and destroys tumor cells, all kinds of things that sound space agey. Nursing diagnoses that would be appropriate for someone with lung cancer: ineffective airway clearance, anxiety, ineffective self-health management, ineffective breathing pattern, impaired gas exchange, would all be very appropriate probably for someone with lung cancer. The overall goals for patients who have lung cancer are that the patient will have effective breathing patterns, airway clearance, adequate oxygenation of the tissues, that they will have minimal to no pain, and a realistic attitude about treatment and prognosis. Some of the health promotion activities that nurses get involved with, and of course this is, where you really need to educate yourself and, be a good role model. And if you do smoke, you really need to think about what kind of message you're sending to everyone, not just your patients, but everyone you come in contact with. The best way to halt the epidemic of lung cancer is to prevent people from starting to smoke, and for smokers to stop smoking. When I started nursing about almost 40 years ago, there were smoking lounges at the end of every nursing unit. Sometimes the patients could smoke in their rooms. Not I personally, but the nurses could smoke during report. The doctors could smoke, in the nurses' station. It was a completely different world. And I've seen over the years, the gradual disappearance of the nursing, smoking lounge and the patient smoking lounge, and to the point now that all hospitals are smoke-free environments. And, you saw where the healthcare workers were going across the street from the hospital to have their cigarettes, and then that was banned because people still saw them, doing that across the street, and it was not sending a good message. So you just need to think about what you're doing, when you are smoking, and see if there's something you can do to stop. We know that, most people start smoking when they're teens, so most smoking educational programs need to start, in middle school at a very young age. And I think we're making some progress. We've certainly seen, smoking commercials banned on TV and a lot of positive things happening. People can't smoke in bars and restaurants anymore for the most part. And actually, I've heard now that hospitals are actually testing people they're going to hire for nicotine, and they won't hire you if you test positive for nicotine. So they're really, really taking it seriously. So any of you who do smoke, you may have to find a way to quit before you get a nursing job. So, that way you'll be able to preach to your patients a little bit more credibly when you tell them they need to stop smoking if you had to stop yourself. Anyway, that's the end of the lecture. Hope you, if you do have any questions, you can always email me if there's anything that wasn't clear. I hope you have a good night.